As most physicians realize, there are 80 distinct types of non-Hodgkin's lymphoma, and there are about 80,000 cases per year in the United States. But of course, some subtypes are more common than other subtypes. When you think about breaking down the lymphomas, we categorize them into two general subtypes. One is the aggressive lymphomas. The second are the indolent lymphomas. The aggressive lymphomas, as the name implies, are fast-growing diseases that can be cured with combination chemotherapy in some fraction of cases. The indolent lymphomas we don't think of as curable. They can be managed, oftentimes now conservatively, and oftentimes now for many, many years, if not actually decades. The most common form of indolent lymphoma is follicular lymphoma. Follicular lymphoma accounts for about 20 to 25% of all cases of non-Hodgkin's lymphoma and has an incidence of about 14,000 cases per year in the United States. Follicular lymphoma can also be subcategorized depending upon its grade. We break it into grade 1, 2, grade 3A, or grade 3B. The grade 3Bs are really treated like diffuse large B-cell lymphoma because they have a preponderance of large B cells, and more often than not, those patients should get an anthracycline-based chemotherapy like R-CHOP. The grade 1, 2, and grade 3A we consider to be more indolent diseases, and one can opt for more conservative approaches for the management of those particular grades of follicular lymphoma. Marginal zone lymphoma is also a relatively rare disease. We think it comprises about 8,000 cases per year in the United States. It accounts for probably 6, 7, 8% or so of all cases of non-Hodgkin's lymphoma. Marginal zone is also subcategorized into three entities known as nodal, a presentation that involves predominantly lymph nodes, what we call extranodal, a presentation that involves extranodal sites. Most physicians will recognize the extranodal subtypes because gastric marginal zone lymphoma, for example, is due to Helicobacter pylori. You can have these marginal zone lymphomas of the skin. We call them SALT. And you can get them in other extranodal parts of the body. And then the third, less common subtype is called primary splenic marginal zone lymphoma. And that entity, as the name suggests, is associated with splenomegaly and oftentimes the presence of villous lymphocytes in the peripheral blood. And one can make that diagnosis oftentimes from flow cytometry on the peripheral blood or bone marrow biopsy. The management of the indolent lymphomas, whether it's follicular, marginal, or other subtypes, there are other indolent forms of non-Hodgkin's lymphoma like lymphoplasmacytic lymphoma, Waldenstrom's macroglobulinemia, small lymphocytic lymphoma. And there are subtle differences in how people manage some of those diseases. But for the most part, the management of follicular and marginal zone lymphoma is tailored to the intensity of the disease. So for patients that have symptomatic presentations or presentations that appear to compromise vital organ function, then some form of chemotherapy is warranted. More often than not, that chemotherapy is bendamustine based, although you'll see a variety of other regimens used, like sometimes R-CHOP based chemotherapy. And that chemotherapy, whether it be for follicular lymphoma or marginal zone lymphoma, is usually tailored to the disease burden. Does the patient meet the criteria for chemotherapy? Some of those cases you can get by with mere observation. Not everybody who presents with these diseases needs to be treated at the outset. In addition, there's an intermediate area where there's some patients that don't need the aggressive form of treatment with chemotherapy plus Rituxan, and they probably shouldn't be watched. And many of those patients can get monotherapy with an anti-CD20 based antibody. So oftentimes what physicians try to do is tailor the intensity of the treatment to the intensity of the disease. and recognize that these are typically chronic diseases that the patient will often die of, frequently not die from. And so thinking about how to manage the toxicity burden of different approaches becomes really critical for thinking about the long-term management of these patients.